Welcome everyone. Today we have our last episode on this conference, healthcare related conference, and we do discuss on public health, equity and justice. And we have our world famous speaker, Professor Edward, Professor Adrian, Professor Rob and Professor Viva. And hopefully we will get a very interesting outcome already. This is very good news that we are collaborating and connecting with different universities, even from India, Indian Global Chamber of Commerce from Ahmedabad, with 10,000 of the corporations. They are also interested to collaborate with World Talent Economy Forum. And our speakers, our honorable speaker, they are really valuable, how they bringing different thought, different strategy for these discussions. It's really appreciable by the think tanks, by the governments, corporations. So hopefully in December, maybe we can go for the offline conference, and that time we can do a lot of networking, lot of offline activities in Malaysia. I want to start from Professor Viva. I think she has a presentation, and hopefully it will be really helpful for us.
Okay, well, on the topic of healthcare, our air quality, of course, is very much at the forefront. And I work in a little area around air quality that has to do with the natural ability of the atmosphere to cleanse itself. And on the theme of moving backwards to go forwards, you know, I tell people that we have actually lost a lot of ground on the atmosphere's natural ability to cleanse itself. So the hydroxyl radical is naturally made in the atmosphere through the breakdown of ozone and also the splitting of water. And the levels of pollutant in the atmosphere that are have been happening to the point where it's taken away the hydroxyl radical's ability to maintain a clean atmosphere, and it's done it not just 10 times over, but humanity's pollution pulses have done it about 100 times over. So this is the hydroxyl radical story about how it's been overwhelmed, just in a very brief. Can you see the screen, Sharif?
No.
Okay. I hope I can get it. Almost there. Okay. Yeah. Can you see this?
Yes.
The hydroxyl slide?
Yes.
Yes, okay. I don't know how well it's showing up there, but I will put it on the first slide. Okay, so the hydroxyl is the most neutral cleanser in the atmosphere, and it's the most neutral reactive oxygen species. And so let's have a look at the greenhouse gas levels that are affecting it. We have CFCs at 78 parts per million. We have anthropogenic CO2, which is 70 parts per million over 350 parts per million. So it's in the 420 range. And then methane, which is about 1.8 parts per million. But if you multiply it to its 100-fold potency over the CO2 equivalents, it's basically 180 parts per million. So we're looking at a pretty serious overage in the atmosphere, and we're trying to get back to 350 parts per million. So the fresh air work that the hydroxyl has done is really swamped. It does react with CO2 and rain it out in the weather. It only does a fraction of what's there, but it's significant. It does between 6 and 25%. So what we propose is releasing synthetic hydroxyl, which is identical to the natural hydroxyl, but comes from a factory. that we can utilize to shore up this hydroxyl. Now, the chemistry of the hydroxyl is really important. Coming from a couple of different places in the atmosphere and recycling a little bit, about 25% of it recycles overnight every day. So there's a running inventory of it fluxing in the atmosphere, which is really important for maintaining some level of fresh air. So it still does work, and its constant state flux is about 8 parts per trillion. So every 2 seconds it's maintaining that level. But 8 parts per trillion versus the chart that we just looked at, which is, you know, over 500 parts per million, you know, indicates that we are a couple of orders of magnitude below what the hydroxyl can do. So what we propose is to add artificial levels of it into the natural system, because the chemistry of it is that it doesn't leave any unwanted residue in the environment when you release it. So it will remove all of the synthetic greenhouse gases and particulate matter, and a significant portion of CO2, maybe up to about 60 parts per million, and it'll remove it as mineral carbonates. Okay, so it's important to know that it's already FDA approved for indoor use. So in close quarters, it's also already considered safe. And we thought, you know, that we couldn't impact this, but the scale up of this technology is pretty interesting. Now, it comes from a simple ceramic, okay, that is heated, and then atomic oxygen comes out of the air that is fed into it, and the atomic oxygen combines with water and it makes hydroxyl. So it's a very simple solid state technology with very few moving parts, and you don't have to suck the whole atmosphere to the equipment, which is a huge downside of some of the direct air capture technologies, because it's going to be extremely expensive. So the solid state factory looks like this. And 1,200 of these cells take up a 70-foot by 100-foot footprint on one floor, and that will capture, by dispersal of the hydroxyl, about 25 million tons a year, 25 to 30 million tons a year. And so it's pretty efficient, and it has a pretty small footprint. We can also scrub the air with direct air capture if we want to vastly speed it up, and we can afford to do it. We can bring the atmosphere to the equipment and actually capture more CO2 while doing that. So there are a couple of different ways that we can actually apply the oxide gas. We can pipe it directly into the flue gas, and we call that our smokestack janitor, because it will convert the water in the smokestack to hydroxyl. And the CO2 will come out permanently in the weather system as mineral carbonates. So the power usage is pretty interesting. About 60 megawatts of power would be used over 10 years to do a global scale removal. The ceramics are recyclable, so the solid state technology is backed by this high sustainability. And we know that we can remove about, 240 parts per million of CO2 equivalent gases directly by oxidation with the hydroxyl radical, which means that all of these tipping points that we have will each be impacted by a corresponding apportionment and fraction, which is very important. And we recommend that if we invest in the oxidation of the non-CO2 greenhouse gases, we can buy up to 2.1 degrees Celsius of cooling, which by the time we scale up is what we'll probably need, because a lot of heating is baked in. And we know that the IPCC is very conservative with their estimates, and there are other peer-reviewed literature statements that are getting up in this range now, that this is where we're already baked in. So, we have several advanced oxidation products. We can apply it different ways at the smokestack or to the open atmosphere. And this also is of note as one of the most promising methane removals. And if we're going to have a methane burp, which it looks like we're going into this possibility at the present time, this is one of the best ways to remove methane from the atmosphere, because in nature, the hydroxyl has been the #1 methane sink. So this is very important for everybody to know that of the technologies that are out there, we're probably the forefront, the leader for methane removal. So we hope that we'll get funded, and we think that things just have to get a little bit worse. So unfortunately, that's what's moving the governments right now, is the impending difficulties with climate damages are moving the policy needle. So that's where we're at right now.
Thank you, Professor Viva. From our speakers, if you have any questions to Professor Viva.
Other than very detailed discussion.
Well, so I would like to say a better connection between the topic we're speaking on and the addition of hydroxyl to the atmosphere.
Yeah. Well, yeah,
you're talking about what the topic is supposedly about healthcare. So I get the point. If you can remove the contaminants from the air, that you can reduce the load on the healthcare system. But I do think much of the effort should have been to make that connection, so the audience kind of got that this was connected to healthcare and not connected to global warming.
Well, 7 million people a year die from poor air quality, and several million, now going up to 4, from climate damages, are dying. And the hydroxyl also helps with the water supply and precipitation. It's involved in precipitation mechanics, which help preserve the water supply. So it has some impact on human water supply as well, too.
So what you might want to do is you might actually want to talk about the cost of maintaining the lives of the people that are dying, because that's really kind of that's really on the nose of the topic, is how do you make healthcare viable for everybody? And so reducing the costs associated with caring for people that are dying from pollution would probably be on point. So I just had a concern that people tuning in are suddenly wondering, okay, what's the topic?
I can add that very quickly. $6 every dollar that's spent on prevention like this is worth $6 in saved money in healthcare.
That's a good step. Thank you.
Yes. Thank you. Actually, even this kind of technology, especially for Malaysia, because Malaysia also has some climate change impact, like our temperatures and everything goes high, and definitely if country like Malaysia, we have a different weather and cultures, I'm sure that this kind of technology also for the healthcare system, hospitals, and many places, it will be very helpful. So hopefully we will discuss more. We will do more on research, and we can discuss in an effective way. Even my friend from Sri Lanka, I think he also agree, and he also sharing our content, because maybe they also facing same kind of problem. Thank you, Professor Viva, for your presentation.
If I could add just one more thing. It strikes me from a lot of our conversations with regard to global warming, which is off topic a little bit, but most of them have to do with cutting back on greenhouse gases. This is a mitigating technology, so it might be more attractive to companies that are polluting than actually cutting back on the pollutants, because this is dealing with the problem of more directly as opposed to actually cutting back on the production, which has been very hard to accomplish. So I actually think that the technology shows a tremendous amount of promise.
Yeah, I want to add, because I'm very skeptical of a lot of the projections on global warming, and I give data to show that. However, for example, Elon Musk a couple of months ago announced a mitigating prize for a mitigating technology. And so instead of saying, well, let's shut down economies and let's do all of these damaging things, and he was very clear about that. He said, here's some things we can do. And I'm putting out I think it was $100 million prize to come up with technologies that might, in fact, be cost effective and not disruptive of the economy. So these kinds of approaches, I think, sell for people like me who say, well, look, we can't harm the economy overly because you worry about global warming. But this kind of thing, it seems to me, is not doing that. So I just want to add that this is an interesting approach from my perspective.
That's perfect. Yeah. These are great questions and great points, because we are entered in the Carbon Removal X Prize. And so, we are holding that space already. So thank you very much for that great point.
Yeah, and interestingly, what Elon said was, he said, I'm not an alarmist. I don't think there's a big problem right now, but a century from now, there could be a big problem. So let's try to do something that's kind of minimalist now that has a good effect 100 years from now. So he was somewhere in the middle. So I thought it was a very interesting discussion a couple of months ago. You heard Elon make the announcement.
Yeah.
Thank you, Professor Viva, Professor Rob. Even if Professor Adrian, you want to add some point for this topic, you can add. Otherwise, I want to give chance Professor Edward. Maybe he can add some beautiful point.
Okay. Yeah, I'll kind of have I like to do points. 1, 2, 3, 4, 5. So I kind of have 5 points that I will make, and then open it up for any questions for the next speaker. First of all, I tend not to use the words equity and justice, just because in the United States anymore, those terms have become kind of buzzwords for, who gets entitlements and who gets to steal what from whom. It's unfortunate, but that's the reality today in the United States. What I usually talk about is what is the way to produce and allow and unleash the best healthcare system that's going to help everybody, and rich, poor, whatever. So I phrase it that way, because when you start talking about equity, you should see in this country, we talk about environmental equity, we talk about linguistic equity. You take the word equity and justice and you stick it on the end of a word, and it basically opens up to all sorts of subjective entitlements and things like that. So let's just talk about what can help emerging economies produce the best healthcare system that's going to help everybody. We don't talk about smartphone equity, because in 2007, the first smartphones were introduced. Now 87% of Americans have smartphones, not because we talked about smartphone justice or smartphone equity. We just let entrepreneurs produce smartphones. So that's the first thing I want to sort of say. I'm talking about the whole system. The second thing is this. In emerging economies, obviously the focus should be first and foremost on the basics, things like sanitation, for example. I've done a lot of work with Africa. I know something about some of the countries in India and some of the others as well. Sanitation and basic services really are the start of healthcare, because, again, in Africa, for example, so many deaths come from waterborne pathogens and things like that. And so, for example, in Africa, one of the things that there's an inventor in the United States named Dean Kamen, incredible man. And he's invented the thing called the slingshot. And it's a little device that's like a mini refrigerator. And he's partnered with the Coca-Cola company, which has the biggest distribution system in Africa, to try to get these slingshots to rural areas and to less developed areas. What's a slingshot? Literally, it's a device that you can take mud water, filter it through. You can use energy not from plugging it into an electric outlet, because in many of those places they don't have electric outlets, but you can use almost use like buffalo dung for fuel and produce quarts of clean water. And he's working, for example, this is a private individual working with company partnering with a company, in this case, the Coca-Cola company, to see how he can distribute that and do something that decades and decades of foreign aid in Africa have not been able to do very well. The Gates Foundation, Bill Gates, the Microsoft founder, also has some very interesting, innovative ways that he's trying to deal with basic sanitation, sewage, toilets, things like that. So the first thing to look at especially in emerging economies and in rural areas, is basic sanitation. Also, of course, things like basic vaccines. I mean, smallpox vaccines were very, very, very inexpensive, and making sure that people in not only the West, but especially in less developed countries, get smallpox vaccines pretty much eradicated that disease. So there are a lot of very basic, not very expensive things that can be done that can help healthcare. If you want to talk about it, instead of a sick care system, a healthcare system that keeps people from getting sick. By the way, one of the big, I mentioned in an earlier broadcast that in Chile, and I visited this in the late 90s or early 2000s, I can't remember, that what the government was doing was laying down pipes in areas where they might expect poor people would move in and build housing. And they had one pipe that would put in the clean water and one pipe that would take the sewage out. And then they said, if you build a house where these pipes are, the house is yours. It's called sweat equity. So that was a way of getting poorer people who wanted to work their way up to build a house and to have sanitation. So you have a healthcare issue there, getting rid of the diseases. By the way, this is where science comes in. One of the things that has caused several million deaths in Africa was getting rid of DDT decades ago. Scientists, especially one named Rachel Carson, said, well, DDT is a terrible thing and it's destroying bird eggs and so forth. Turns out the science was not all that good. But the thing is, there was a balance. When you have lots of tsetse flies in Africa, you have millions of deaths. And so there's a trade-off here. So we have to take a look at, well, we all want a perfect, pure world, but folks, you got to look at what the trade-offs are. But anyway, that's the second thing I have to do, is focus on the basics. The third thing I want to mention is the West is not necessarily the model. We have very mixed systems here in the West. We have some systems in Canada, for example, where the government controls all of healthcare. And so you have guaranteed healthcare there. On the other hand, we have a big traffic of people coming down from Canada to the United States because they don't want to wait 6 months for certain kinds of procedures. And I know that I've done some work in that area. We have hybrid systems, which are very interesting, where the government provides some basics, but you can essentially buy into a higher valued policy. I think Israel has one of those systems, and I can name others that have this kind of hybrid system of health insurance with the basics. The American system is kind of a mess, quite frankly. We kind of have the worst of all possible worlds. We have incredible research and incredible technology. We're probably the best in that area. However, the cost system is really out of whack. By the way, I put a link in the chat, and I don't know if you can pull up that graphic, Sharif. One of the problems you've seen in the United States is that over the decades, healthcare costs have risen in this country far, far higher than most other goods and services. And so while we want everyone to have access to healthcare, we have a very convoluted system in this country that pushes costs up, and most people don't look at why the costs are going up. Here it comes. For those of you who are viewing, I don't know if you can see the whole thing, but there it is. Yeah, you can basically see that that thing at the top is hospital costs. Education, by the way, is another thing that's gone up very, very fast in the United States over the last couple of decades. But that's a problem we have in this country, is cost containment. A lot of people don't look deeply at why the costs are so high. A lot of people don't look, by the way, at the fact that in a lot of countries, and this isn't talked about a lot, you have black markets for healthcare. I remember talking to some doctors from Norway, and they were explaining how, yes, we have a system in which everyone is guaranteed healthcare, but what really happens is if you want it to be done faster and so forth, you simply give somebody the money, the doctor, the money off the books. They get a little bit of profit. You get to have the service quicker. That's the real world. And so you have to look at this sort of issue. You have interesting models in the United States where a number of doctors are simply not accepting any kind of insurance because they come with so many strings attached, and they're simply saying, we are going to create a subscription system, for example, and you simply pay a monthly subscription, and then we'll have a rate system. But that way, we don't have to go through all the bureaucracy of the system, which simply raises costs. So, you know, if you're a policymaker in one of the in one of the countries, in India and places like this, be a little bit wary about the system in the West. The fourth point I'll make is, to the greatest extent possible, you have to let the customer, the patient, make choices. That's very important. In the United States, for example, we have a system in which most health insurance is provided through one's workplace, because the employer gets to take it off the taxes. But if I simply pay out of pocket to buy my health insurance, I don't necessarily get to take that off my taxes. And so basically you have a third party saying, here are the things that we will offer, and you take it or leave it. And so it's not like me going to the doctor and negotiating price. You don't have a market system fully operating, and that's part of the problem in the United States. It's a very messy system. And then where you try to push a system where everybody can have access, for example, with the Affordable Care Act, basically what happened, they wanted to try to open the system up to poor people and to everybody who couldn't afford it. And what happened was, in fact, premiums pretty much doubled and deductibles for insurance pretty much tripled. I know, because I was one of the people who had that happen to me. But again, it's just not anecdotally for me. I looked at the statistics. But here's some good news. For example, we have a system in the United States called Medicaid. And this is a system, government system, that partners with the states, partly state funded, partly federal government, national government funded, to help poor people. If you can't afford health insurance, then the Medicaid system will help you. It's an expensive and inefficient system, but a lot of states have gotten waivers from the federal government so they could experiment with patient choice. And that's been very, very interesting. For example, our little state of Rhode Island got what's called a block grant of, I think it was $12 billion over a certain period of time, where they were allowed to experiment. They kept the basic services, but they allowed the patients to make certain choices. And it actually brought the costs down of healthcare in Rhode Island, and yet the quality stayed the same. There were 3 counties in Florida back about 10 years ago, 12 years ago, I think it was, that were allowed by the federal government to experiment with their Medicaid money and to allow patient choice. And again, you got the same results. And I can give other examples of other states that have experimented with allowing patient choices, rewarding patients for shopping around, rewarding patients for basically taking preventive care. And they've been very instructive and successful. And again, any of your public policy listeners to this broadcast, I'm happy to give you much more details about this. But here's the final thing I want to say. This is my point 5. Exponential technology really does offer an opportunity in the future to replace the current sick care systems which we have. Basically, if people get sick, then we talk about who gets to pay and who doesn't get to pay and so forth, with a preventive healthcare system, with wearable technology, for example. Even in rural areas, when I was looking into this, say 10 years ago, I was seeing technology coming on where you have the so-called lab on a chip. I forget the gentleman who, I think it's Whitehead, who invented the lab on a chip, where if you're in a rural area, in a very poor area, you can basically put a little bit of blood or some sort of fluid on the chip. It will analyze a number of factors, and then hooked up to some kind of a system, you can send that information to a hospital that might be 50 miles away, and then they can do the analysis and then come back with a diagnosis. That's just one example that I've seen working in, for example, in Africa. I could give lots more examples, but with wearable technology and with the new technologies that are coming on board, a lot of the, especially a lot of the governments and a lot of the countries in the Asia Pacific area, and I'm thinking especially of Malaysia, Philippines, some of these countries that are fairly advanced in many, many ways, really can take advantage of these technologies and set up a system where essentially entrepreneurs can do for the healthcare system what they've done for smartphones and the communications and information systems. And so you really can create a system in which everybody in the long term benefits, including poor. Because remember, think of it this way. The first people who got smartphones were beta users. The first smartphones were kind of clunky and all, but at least they allowed you to take photographs, listen to tunes, make phone calls, and surf the web. Now these things are much, much, much more sophisticated, and more people have access to them because the quality has gone up and the costs have gone down. That's the dynamism that you want to unleash. So again, in the few minutes I have here, I can't give all of the details of what I found out looking at healthcare systems. But there really are such incredible opportunities, especially in emerging economies, to skip some of the mistakes that were done in the West and to really come up with a system that in 10 years, 15 years, is going to benefit everybody instead of having people wallowing in not only poverty, but in illness for decades and decades, like so many of them have had. So those are my comments. And again, this is very exciting, and I'm happy that governments and entrepreneurs and businesses, especially who can partner on these things, are looking at doing these things in the Asian Pacific countries, because I want you guys to be as healthy as possible. I want you guys to teach us with some of the innovative approaches. So thank you very much for this, Sharif.
Thank you, Professor Edward. From our speakers, if you have any questions or anything you want to add for these presentations, you can add. Professor Rob or Professor Viva or even Professor Adrian.
Yes, I have a question. You look at any of the modern application of bringing people back to more basic diet, more traditional diets in their home countries. Like, for example, one of the huge pipelines into the healthcare system is a low quality diet, which is based on the standard American diet, which is one of the worst things that could ever be exported to the world. So there are apps on your cell phone that you can get that can track all your macronutrients and stuff. So you can look at your fats, carbohydrates, and proteins and balance out your diet. So this is right on theme, actually going backwards a little bit away from processed foods back to whole foods and using technology to do it, so that Asia Pacific countries can avert the health disaster of diabetes and inflammation related illnesses that have cropped up now.
Yeah, I think you raise an important point, and I'd say a couple of things. First of all, there always are trade-offs. The mass production system in the United States, and by the way, I say in other Western countries, has certainly eliminated the problem of starvation. In fact, we have obviously the opposite problem because we're so efficient and so effective that we have too much stuff. When I say too much, we have more than we we don't have any shortages. Let's put it like that, okay? And what that means is that a lot of people's diets are not particularly good, and part of it is because fast food is easy to get, and plus, there's another issue of raising consciousness about diets, because the first thing you worry about is whether you're going to starve or not, and whether you can afford food or not. And so when the cost of food go way, 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 way down, which is done in this country over the last 50, 60, 70 years, then great. Now I don't have to worry about where the next meal is going to come from. I only pay this small percentage of my income for food, so I've got more for housing, for entertainment, for healthcare, for all these other cool things. That's good. But then you start to look, and I agree, by the way, that you start to look at these other things. Now, one of the problems becomes the economics of it. And I've looked into this a little bit, and it's certainly worth looking into more. If you go to certain, for example, production processes for food that are not the sort of thing, a lot of the things that we do in this country, then you're talking about a whole lot of costs. And so then you get into the issue of whether you're going to start pushing up food prices. The example I give in the United States here is we have and the Asian Pacific folks might not appreciate this, but we have a store called Whole Foods, and it specializes in organic foods and foods that they don't use pesticides on and so forth. And the food is no doubt very, very healthy, and it costs 2 or 3 times as much as food that you would get in your local grocery store. And so the people who tend to go to Whole Foods are, people who have a lot of money and not people who are the poor, because again, this discussion is about equity and justice. I don't like to use those words, but I appreciate the sentiment. What I would say, and I've said this on some previous broadcasts, is that I think in the future, the exponential technologies are going to allow us to raise consciousness about this and hopefully act upon this. For example, and we have a Fitbit watch now you can wear. You can have an Oura ring. These things, every time I go jogging, it gives me all the information about myself. And I think what you're going to be able to see in the future, 5 years, 10 years, probably more like 15 years out, is with wearable technology, certainly in the developed parts of the Asia Pacific areas, in Kuala Lumpur, Singapore, Japan is probably already doing this. I can name other areas. I will have my genome sequenced. In 2001, it cost $100 million to sequence a genome. And I like to brag that it was done 6 miles from where I'm sitting here in Rockville, Maryland, by a guy named Craig Venter. Great entrepreneur. It cost $100 million. 2007, it cost $10 million. I can get it done for $500 right now. I'm probably going to have that. So what I'm seeing in the future is more and more people will get their genome sequenced. They'll see all of the issues that they're susceptible to. And they will have wearable technology where in real time information about their bios are going into a database. Supercomputers and AIs are going to be looking at it and saying, Ed, your sugar levels are a little bit too high. I know that you just had ice cream because you had a party with your children. Okay, but just be a little careful about it. But here's the other thing, linking that to insurance and payment. One of the problems you get in a collective system is, let's say I'm very healthy. I go jogging every day. I watch my diet. I try to be as healthy as possible. And then there are people who eat nothing but fattening foods. They don't exercise and so forth. And if I'm going to pay for their health care and they're going to be shielded from the consequences of their bad actions, that's a bit of a problem, right? So we do have that whole thing. And I'm for civil liberties. I don't want to go in and tell somebody you can't do this and you can't do that. But what I'd like to do is, just as we've raised consciousness about smoking, okay? I'm not necessarily for banning smoking, but what's happened in the United States is in the 1950s, something like half the population smoked. My grandfather died, by the way, from smoking and from lung cancer. Half the population smoked. Now it's about 15%. By the way, vaping is one of the best ways to get people off of tobacco smoking. It's much safer in the British. I'm sorry, I can give you the citations. I've looked at the British Medical Society, the British Royal Society, and all. It says vaping helps get people off of smoking. The point is this: people's consciousness has been raised about the dangers of smoking. And I want to see the same thing about diets. And I see a possibility of doing that. By the way, my sister died, I think it was 11, it's gone on to 12 years ago now, because she was obese and she had diabetes. And we tried to do everything we could for her. And it was unfortunate. She was a wonderful woman. I wish she were still around. She'd be babysitting my kids right now. But the point is, I think that's something in the future that we have to raise consciousness about, just like we did for smoking. And so your point, I think, is quite well taken.
Mm-hmm. Thank you.
Thank you. Anything Professor Ed, Rob, and Professor Adrian want to add with Professor Edward?
Well, I want to disagree with the vaping versus smoking thing. I think it's the difficulty we're dealing with right now is we don't know the health impact of vaping. Most of the medical texts come out and indicate that the risks are significant, but we don't have enough data to determine how great they are, and it's still an addiction. So the better alternative is to get people off of these addictive drugs and move them to behavior that is much healthier, and where we know the outcomes are going to be. Out here, we banned because there was such a focus of advertising on children vaping. Much of that's been banned and reversed because kids just don't know any better, and so they build up another habit. And even if the health risk is minor when you start young and do something throughout your life, the aggregate impact can be significant. So switching one addiction to another just isn't, to me, a viable way to fix a problem.
Yeah, the thing
it's much like some of the mitigation efforts to take people off of harsher drugs. Often the cure can be nearly as bad as the problem you're trying to correct.
Yeah. By the way, I'm not advocating that everyone go out and vape. By the way, I'm addicted right now to a thing called caffeine. I'm doing it right now. Yeah. Yes. I see you're doing it right now. But the data I've seen is that during a period of, I think it's 5 or 6 years, something like 3 million people got off of in America.
It is effective to swap people off smoking, but I think we've just got to figure out if you're moving from one thing to the other. And vaping is arguably safer than smoking, but it's not safe. And so there are side effects and risks that aren't well understood.
Yeah, the data I've seen. Yeah, the data I've seen, and especially the Royal Society in Britain and the British have done a lot of good work in this area. And it basically shows that most of the carcinogens and other toxins are released when you burn tobacco. And again, I'm not advocating for anyone on this show to go out and start vaping. And by the way, it's expensive, so you better save your money and use it for other things. Use it for coffee, okay?
Right.
I think we agree on the bottom line. I think.
Right. I just be aware the American Heart Association has come out hard against vaping as being dangerous. So anyway, just being clear. All right.
Sure.
Thank you. Now I request our honorable speakers, world famous scholars, Professor Rob. So let's start.
So the Edward brought up Obamacare, Affordable Health Care Act, and I covered that pretty extensively as it rolled out. And the analytics underneath were kind of interesting. One of the problems with the effort was the analysis that went on ahead of time to determine whether it would be economically viable or not. Didn't look at mental health. The underlying assumption was that kids who were healthy would contribute enough into the system to pay for older folks that were not. So you had people that were overpaying at youth and underpaying as they got older. And the thing balanced out, but it only balanced out because they left out mental health. Kids used an inordinate amount of mental health. And that meant the kids were not contributing positively to the system. They were also funding negative. In other words, they were costing the system more than they were contributing. And that blew up the financial model. And then the Supreme Court ruled that the mandatory payment for healthy people was unconstitutional. It was a taxing effort that hadn't been properly approved. And so that other economic aspect was removed, and that made the Affordable Health Care Act unaffordable. And the mistake was economic. And that's often the mistake that's made with regard to these large programs. People want the program to happen so very much that they don't do adequate analysis, cost benefit, and cost revenue analysis to assure that it's going to be viable. And the end result is not. And instead of being a showcase of how to do healthcare properly, it becomes yet one more black mark on trying to make healthcare a right as opposed to a privilege. And I am one of the folks that tend to believe that healthcare should be a right, not a privilege, only because of the economic impact it can have on individual families, and because the insurance model as it is generally carried out isn't really that viable either, given the disparity of coverage we get between those that have and those that have not. And the people that have can actually afford to incur the kinds of costs that they may have to incur in healthcare, and the people that have not cannot. So it's providing an uneven method of handling a populace, and sick people don't contribute. So when you're talking about a society, often the folks that aren't making a ton of money are actually doing a lot of the work that keeps society running. They're driving the buses, they're handling transportation, they're picking up the trash, they're doing the things that are necessary to keep society, well, as I said, functioning. And so denying them access to healthcare is one way to kind of create a black eye and an ineffective model. So the first step in any type of healthcare reform or healthcare effort and efficacy is to really understand the costs that you're incurring for healthcare and for sickness. And here's not just the cost that's going to hospitals, but it's the cost in terms of economic production, because as I mentioned, sick people don't either underproduce or they don't produce. And clearly dead people aren't really much of an asset either, and their costs associated with people dying, including, as we discovered during the pandemic, the disposal of the bodies and the economic shutdown of the state that they're in, because when you have lots of deaths, governments just don't typically survive that. So the goal of government should be to keep people healthy, keep people alive for long periods of time, and we do have technology that is advancing. One of the interesting efforts was an effort that was co-funded, and I've just posted the link, by Cisco years ago for neopenda, and the problem was prenatal care in emerging economies in places like Africa. The cost of a natal monitor wasn't affordable, and children need to have a monitoring. So neopenda came up with a solution that costs very little. And you could put a monitor on a child, you can keep track of their health, and you can get them the health of a newborn, get them the health that they need, for very little. And this was fun. This was co-funded by Cisco, but certainly could be, these kinds of efforts could be funded by the government as well, looking for ways to apply technology to provide basic care for people. Does begin with some type of a sensor, because if you can monitor a person's health real time, not only can you tell who's sick and who's well, but you can look at trends across the state. So if suddenly your sensors start spiking and people are getting sick, you've got a problem. You can send investigators in, and you can say, okay, maybe the water. I mean, we just nearly had a catastrophic water event in Florida where a hacker went in and increased the chlorine count in the water to near deadly levels. Unfortunately, it was caught and stopped. But had he not caught that, he or she, actually, I don't know who caught it. He or she had not caught it, we would have had a spike in illnesses and deaths that would have probably either been picked up when people started showing up at hospitals, or if death counts started going up, which is too late. Where monitors would have picked that up much more quickly and maybe stopped it before a lot of people had died. As I mentioned, the person working on the system caught that as well. And that's another instance of where, given the environment we're in, part of taking care of people is assuring the healthcare systems are secure and they don't get hacked. If you've got a hospital that goes down because of ransomware, yeah, you've got a ransomware problem, but you also have a major healthcare problem, because that hospital can no longer function. It can't access records. It can't provide regular healthcare. And the other big issue we've got right now, particularly with regard to the pandemic, is data sharing. We're not doing a good job with regard to data sharing, which means we're not able to get the remedies. We're not able to find out which remedies work fast enough, and we aren't able to get those remedies to the people that need them fast enough. It took way too long to find out that remdesivir actually works, and it took way too long to find out that hydrochlorozone does not. Those were mistakes that had significant impact on people, and people are still running around trying to take hydrochlorozone. The ability to get people the information they need timely, and to get the medications to the people that need it early on, particularly in something like a pandemic where you've got a spread problem, is absolutely critical, as well as monitoring the spread. If you have people that have sensors on them and you can see the progression of an illness, then you can respond to that illness progressively. See, it made no sense, for instance, for us to shut down areas in the Midwest that had not yet experienced COVID under the assumption that they might experience it. It looked foolish to the citizens. It was foolish in practice. Mitigation should have been limiting travel, not shutting down the economy. That would have stopped the pandemic from spreading to an area that was not yet infected. But shutting them down did no additional good near term. And it did increase the economic impact and significantly increased the blowback and people not willing to follow government regulations, which actually made the risk greater than it needed to be. So practices have to match the problem, and it all goes to the heart of analysis. The idea of throwing remedies at a disease is foolish. It's expensive. Particularly when you can do the analysis and determine relatively quickly, if you've got data access, which remedies work and where to apply them. And so you can take the resources you have, and you can effectively apply them to the problem you've got. If you do it any other way, then you are overspending on resources, and you are under executing on mediation, and those things are not going to bode well long term. So the first step really is to analyze the problem, and every state has different problems. Hot states have issues with diseases that are connected to heat. For instance, out here, regardless of whether you believe in global warming or not, we just had more deaths due to heat in a week than we typically get in a season. And regardless of whether this is a spike or whether it's a long-term trend, finding a way to mitigate that is going to be critical going forward, because we can't sustain these kinds of double-digit losses every time you've got a heat event. And that's even outside of the fires that are taking out towns and cities at the moment and causing additional deaths and grief. So you have to prioritize the issues that are killing and making your citizens sick. You have to prioritize the remedies that address those issues, and overall, your goal has to be data-based, where you can analyze the problems accurately. It's less about providing pharmaceutical companies with profit, and more about keeping people alive and well. And in most of the analysis I've seen, it is far cheaper to keep people healthy than it is to try to get them well once they're sick, because the economic impact alone of lots of people being sick is unsustainable, and as we saw during the pandemic. So at the end, and at least as technology can address this, it begins with heavy sensors, it begins with heavy analysis, and then that analysis then feeds the solution that you apply against the resources that you've got.
Thank you, Professor Rob. From our speakers, if anyone want to add some point or want to ask any questions to Professor Rob, Professor Adrian, Professor Edward, and Professor Viva.
Well, other than the fact that I see that we actually agree on the importance of sensors, the importance of monitoring, and the importance of data analysis to basically target the problem, try to mitigate the problem before it becomes serious. And to me, again, that's creating a real healthcare system, as opposed to, as you say, a sick care system where you wait for everybody to get sick and then we have this big fight about who should pay for it. So I think we're actually in agreement. Maybe we disagree with some details and so forth, but I think and by the way, you're also right, very correct, I think, about the regional issues, because that's a difficult when I'm talking about Asia Pacific. Am I talking about rural India and Bangladesh? Am I talking about sort of inner city areas that are very, very poor and with poor sanitation and so forth? Am I talking about a very advanced city like Singapore, which probably doesn't have a problem? You really have to understand that what is really useful in Wyoming and Montana and Idaho in the United States is not necessarily the best approach for Los Angeles or New York City or whatever. And so I think we're all in agreement on that. And again, I'm looking to that as the future, where we can actually agree across party lines, ideological lines, and so forth. And I hope the Asia Pacific people will see that Rob and I actually agree on something. So that should really say something about the truth of what he is saying.
Thank you.
Thank you.
I wanted to just make two questions for Rob. If you had carte blanche, would you do anything in addition to the nutritional advice that is found on food in our typical markets, or how would you harvest and generate more data now that we know that so much illness is borne by our diet? And also the other one is, what kind of technology platform would be really great for rural India to actually get blood pressure and basic healthcare parameters like blood pressure and other basic biomarkers into the hands of developing countries and particularly poor countries?
So answering your first question first, in terms of the information on food, I think the critical aspect of whether we're talking about food or pharmaceuticals, blocking lobbying into your government would be critical. Because you've got to be able to make your decisions based on data. Mm-hmm. And if you get large organizations, whether it's petrochemical, smoking, the cattlemen's associations, the different organizations that are well funded, but trying to protect their economic models, where they're preventing the information that you need to make viable decisions from coming forward, that has to stop. You're perfectly welcome to eat meat if you want to eat meat, but you should understand the risks, the legitimate risks that you're taking while doing so, and the efforts to block that same kind of. I mean, we knew the smoking history knew for decades that smoking was deadly, and smoking took out a good number of family members that I've got as well, and it's a bit upsetting. Much like the asbestos industry covered up the problems with asbestos before, and my sister-in-law pretty much died from that stuff. So at the end, if you can't get the data through clean so you can make decisions, that's a problem. And the large industries are corrupting the data that's coming through, and so the decisions to mitigate problems are too late, and your choices are being corrupted by the people profiting from your sickness and death, and that's unfortunate. I mean, you have to fix, and you can't fix a problem. It's very likely you can. We already know that with regard to greenhouse gases, if you just change the diet the cows eat, you can reduce the damage that they do to the environment. But that's data we should have had decades ago. Same thing with petrochemicals. There were studies that were done in the 1920s that said moving to a petrochemical society was going to destroy the world, all suppressed by Standard Oil at the time. And that was because Standard Oil got too strong before the data came out, and the data was blocked. We've got to make decisions based on scientific research. Otherwise, we're going to. It's that if we look at the Hadron Collider, there was analysis that was done that indicated that the chance of destroying the world was almost impossible, except reviews indicated that it was 2 magnitudes off in the wrong direction, which means that's the kind of mistake you don't want to make. I mean, if you're talking about a chance of turning the world into a singularity, you want that to be pretty safe, because it's not like we can move someplace else. And so the data has to flow through. As with regard to monitoring, in your second question, the Neopena thing that I provided as an example, the showcase of how industry can get involved to develop low cost. Adrian, you want to? Okay, that can get involved and can contribute to creating low-cost sensors and apply those sensors in an economy that otherwise can't afford them. So I think if you use the Neopena example, Neopenda example, that's the process to get sensors onto people so you can do things like monitor blood pressure, monitor diabetes, monitor heart rate, monitor temperature on an active basis, and you can see the progression of a problem in an area, and you know to deploy resources before it gets out of control.
And also, Edward mentioned lab on a chip. Does anybody know what the current advanced state is for getting blood work done remotely on lab on a chip?
We're not there yet. So we barely got to the point of being able to measure blood sugar at scale. We've been able to do heart rate for a while, but cheaply, accurately has been a little troubling, because really where you have to place the sensor for that better is on your chest as opposed to on your wrist. But at least we can do that stuff. But doing major analysis on a chip, that's still beyond us. Might be something we're capable of doing by, say, around 2040. Yeah. But at least on what I've seen, that level of complexity and whether or not you'd actually have to penetrate the arm and surgically implant it, which would be the easiest way to solve that problem. It's got implications that religions aren't going to care for. Invasive technology. I mean, we've got people running around here talking about they believe that the antivirus contains magnetic material, and chips that Bill Gates have created. So in the face of that kind of craziness, getting something that actually did this stuff through approvals would be problematic right now. But that's the future. So figure around 2040, 2050, we'll probably have a reasonably priced solution. Then we'll have to get through regulatory approvals and overcome a lot of the negatives associated with people saying, "Hey, you're putting a monitor in me. I'm not sure I'm okay with that."
Yeah. By the way, I think it's going to come a lot quicker. I agree that we're certainly not there yet. We're right at the beginning with the technology you mentioned.
Well, the technology will come quicker than the approvals. Yeah. I think the societal acceptance is going to lag.
Well, okay, I've spoken many times, as you know, on our FDA and drug and medical device certification process in this country and how completely broke it is. Yeah. And it's right here in Maryland, and so that's a whole nother discussion. By the way, Rob, one other thing I'll take exception on is
Sure.
I agree with you about the problem of interest groups. But the problem is, for example, I looked at when we had the issue of synfuels as a way of mitigating global warming and doing things like that. And a lot of that was simply the corn lobby basically saying, hey, we've got a way to do this sort of thing. And what it did, it drove up prices for certain corn-based foods, which is a staple in Mexico, for example. Or you take a look, for example, at the adverse effects of some of the some of the alternative energy things like solar panels and the waste. So while I appreciate what you're saying, and again, I've been someone who's, doesn't mind criticizing industries. Right. I worry that if we basically say, well, we're just going to have the experts, because I have to deal with the experts at all of these government agencies, I know they have their vested interests as well. And so I worry about that. I want to have a more open system, but I appreciate what you're saying.
I think we're in agreement, because my point is you have to have the data, whether it's the corn industry corrupting the data, or the solar industry corrupting the data, or the wind industry. You can't have data corruption because you can't make decisions that the data is corrupted. The bigger problem with corn, and you mentioned corn, was simple syrup. Driving sugar out, which was unhealthy, but replacing it with simple syrup, which was dramatically more so, was not good for was certainly not good for the environment, and that was driven largely by the corn lobby. And same thing with regard to using corn as a fuel alternative. That created a whole bunch of secondary problems. You have to make this. You want to fix a problem with something that's as bad or worse than the thing you're trying to fix.
Right. Yeah. By the way, I have to go. I just have something that just came through on my phone. So this has been a great discussion. Sorry, Adrian, I'm not going to be able to hear you. Maybe I'll catch you on the recording. I'm sure you're going to do a great job.
Thank you.
Everyone keep up the good work.
Thank you, Professor.
Thanks a lot.
Thank you, Professor Edward. Thank you. Thank you.
All right.
Now,
okay, Professor Adrian, you're up. It looks like Sharif is frozen.
yes, sorry. No, actually, something happened. I'm sorry about that. Yes, Professor Adrian. Yes.
It's been a fascinating discussion. I'm not a health expert. I'm an electrical engineer, but I may have a few comments. So I live in Asia Pacific. I've lived in Malaysia, Singapore, Hong Kong, Japan, and Australia, where I was born, and right now I'm in Australia. And so there is, I would say that Australia and Japan basically have, I would say, quite a, let's say, socialist kind of system where healthcare is provided to everyone for basically free. In Japan, I think the user has to pay about 20%, but in Australia, 100% of all medical costs are covered, basically. And so we have a very similar system to the NHS in Britain, which is not surprising because most Australians came from Britain in the first place 200 years ago. But in Malaysia, although it's a poor country, I found surprisingly medical care, even if you pay the full fee, is extremely cheap. This is probably because salaries and wages are much lower than other parts in the world. But the government does subsidize healthcare a lot. So, it's people who went to I had a friend. I personally had experience where one of my daughters had to go to a public hospital because it was emergency, and even though they did many X-rays and a lot of other things on her heart, and the heart expert came. I think the fee was $2 or $3 for a 1 week stay. So I think there's heavy subsidization by the Malaysian government. So I think Malaysia also has a very good healthcare, even though it's not a universal healthcare like Australia. And there was some talk about drugs before, and I would like to put a little bit different perspective that if you look at the if you look at the 19 the 19 I think it was 20s or 30s when they had prohibition in USA, that really led to the rise of the mafia and related groups. Because they made a huge lot of money to sell illegal alcohol. And most drugs actually, surprisingly, were legal until late 50s or early 60s. You know, even things like heroin or cocaine and a lot of other things were actually legal. So we tend to think that these things have always been illegal, but they have not. And I think we see exactly the same thing, that people don't stop taking the drugs, but you get the organized crime being able to make a lot of money, and you know, the people who normally are in organized crime are not very nice people normally, so they will, you know, if you double cross them, they'll, you know, it's not like a normal business deal. You know, you get shot in the head by some hitman or something. And we're already seeing the legalization of marijuana in Canada. I think Mexico already. I think some other country. I think over 20 US states have either decriminalized or legalized marijuana. California is one of them. I was there just a few months ago. So my personal view is that all drugs should be decriminalized and even legalized. So, for example, marijuana, I think, is a relatively uh, maybe not harmless, but relatively not dangerous drug. So the government actually can, you know, raise a lot of money by selling marijuana as they're doing in Canada. And then so that's my perspective on the little discussion there was on drugs. And I'm not sure if you live in Malaysia, so they're very, very strict on drugs. So please don't tell the police to come and get me. But this is my personal view. I know they're very strict in Malaysia. They have a death penalty for drugs there. Very severe. Actually, Singapore is the most severe, I think. Malaysia, maybe not as severe as Singapore. So yeah, that's a couple of feedback I would like to say so far.
Thank you, Professor Adrian. Thank you for joining today's session. This is really great session and great conference with the help of all of our scholars, Professor Viva, Professor Rob, Professor Adrian, Professor Edwards, and 30 different speakers. They joined and they're working with us for this conference. Hopefully, the next month we will discuss with other issues and which will actually helpful for our Asia Pacific communities. And thank you for joining today's sessions. And if you have any concluding remarks from your side, first Professor Viva, then Professor Rob, and finally Professor Adrian can give for today's session.
I guess the main thing as we look at, you know, a planet that has people living in the Stone Age still all the way up to the very modern levels that we're working at, even though we have lots of flaws, is the principle of prevention. So, you know, Asia Pacific can look at the Western culture and see the mistakes that are made and avert a lot of cost and a lot of loss in terms of human resources by being, you know, analytical and working out their own analytical processes around some of the basics like healthcare and food and, you know, air quality, you know, things that we're all in on collectively, but we all also have to manage at regional and local policy levels. So that would be my concluding remark.
Thank you, Professor Rob.
So years ago, Bill Gates was in a conference, and his conclusion was, and the conference was about how to sell technology into emerging countries, and his conclusion was, and one of the reasons why he retired from Microsoft and became a philanthropist, was that if you can't assure clean water, adequate food and medicine, you're not going to sell anybody personal computers. Because people that can't afford to eat aren't going to be your primary client base for technology. And the underlying point here is these are things that are critical to any society. If you can't assure clean water, adequate food, and medicine, the government isn't doing the job. And so that's where it starts. And the way that governments get corrupted is both from folks that really don't have citizens in their best interests that are funding the government, bribery or lobbying, depending on which region you're in, and then the corruption of data. So even if you've got bureaucrats that want to do an honest job, if the data they're receiving to make their decisions is corrupted, they're not going to be able to do a good one. And so the very first stages of addressing problems in areas is to first assure the basics: clean water, good food, adequate food, and medication. And I think part of how you do that is you make sure the industries that are polluting pay to clean up the pollution. They're incurring the cost, and the state owns the common resources. So in theory, the air, water, at the very least, air and water at the very least are typically state-controlled resources. And if private entities are polluting those resources, it's up to the state to make sure those private entities pay to clean them back up again.
Yeah,
and if you can close those economic loops, probably a lot easier for a developed country than a country that's developing. But if you can close those economic loops, you can fix a lot of wrongs. But if you can't keep politicians from being corrupted, and you can't assure the advocacy of data, you're never going to fix a problem like this. You are basically working in a corrupt system that is working against your citizens, even though you intend it not to be. And if you can't fix that, then you're probably just hitting your head against the wall, because you're probably not going to make progress. I did get a kick out of Professor Adrian's comments with regard to illegal drugs. I view that personally. My own personal view in that category is that these things should be taxed and not made illegal. And because what it does, it creates a level of attraction. We as humans tend to want to do things we're told not to do, and I think we're unintentionally promoting some of this stuff with our underlying approach. But I do think that the priority should be placed on those drugs that are making people sick and causing a load on the healthcare system, as opposed to those that are not. So once again, the government is reacting against the threat, as opposed to reacting broadly against an entire category. And at least here in the United States, we're going through a process where we are legalizing certain categories of recreational drugs and finding they can be revenue sources as opposed to money holes. But that's part of how you look at a healthcare system. You look at a healthcare system and you look at those behaviors that are economically viable, like assuring people get good exercise, assuring people at least have the information they need to make good decisions with regard to what it is they're eating or drinking. And if you're going to apply penalties and taxes, you apply them against things that make them sick, make them ill, and put a load on the healthcare system. And you don't probably spend much time on those things that do not. And you certainly look at past decisions where you may have favored one industry over another that made things worse as opposed to better, and correct those decisions. But that's all about still going back to, you have to have clean data. You have to be able to prioritize your problems, and then you have to be able to resource the problems at the higher priority. If you can't do any of that stuff, you really can't address this problem.
Mm-hmm. Thank you. Professor Adrian, what's your concluding remarks today?
Yeah, well, I just add to Professor Rob's good comment. In a country like Australia, you can tax things very effectively, because it's a big island in the middle of nowhere. So alcohol, for example, is unbelievably expensive. Of course, alcohol is legal in Australia, but extremely expensive because it's very high tax. And there's no way to smuggle alcohol into Australia. The cost of it would be more than the tax, because, like I said, it's a big island in the middle of nowhere. Whereas I found in Malaysia, there was lots of places you could buy, let's say, tax-free alcohol because they just run it across the border from Thailand or something. So it really depends on the country. And I agree with you that we instead of we should decriminalize these all the drugs and tax them. But the problem is what we're seeing in Canada is people are still buying the illegal marijuana because the tax is much cheaper. So you have a kind of dilemma. You can't tax it too high, otherwise the incentive to just get the illegal drug is still there. So there's a balance, I guess, you have to make. Add the tax, but not tax it too high, so people will buy the legal drug, and you can use that tax for healthcare or other things, for education or anything. And people and if you look at other areas, I'm not sure about in USA, but in many countries they have a national run lottery where essentially it's you're getting people to gamble, and then all that money is then put into education or other good causes. So there is many examples where you take, let's say, bad habits and use the money for good purposes, and so that could apply to drugs as well. The topic of this talk wasn't about drugs. Maybe Sharif, you should make another topic about drugs and legalization. That would be a good 1 hour talk, I think, for in the future. But yeah, so I agree with Professor Rob. But there's, as we've seen, it depends on the situation. If you have a country like Australia, you can do it. Japan, island state, far away from other places, you can do it. But you can't really do it in let's say USA or Canada, because it's easy to, once you tax too high, it's easy for people to smuggle across the border, and people will buy the illegal versions of the drugs. By the way, we can talk about legal drugs as well. Just legal drugs are much more expensive in USA than almost any other country. And although Trump talked about it, I don't think he really actually did anything about it. But he did have a good talk about it, saying that the pharmaceutical companies are, price gouging the American people. And as I said, I lived in Malaysia, and you could buy medicine at incredibly cheap prices compared to America. So Trump said that he wanted to take on the pharmaceutical industry, but I don't think he did. But that's another thing. Even legal drugs, unbelievably expensive in places like USA, and it's not very fair on the American people, because not everyone in America. Well, I'm not sure it's true, but I read somewhere that most American people only have $400 in savings, right? So even though America's the richest country in the world and a very, very rich country, not everyone is rich there. A lot of people are just barely surviving. So we should even think about the American people, and the pharmaceutical industry is price gouging the American people. Thank you very much. It was a great discussion.
Thank you. It's really great discussion, and thank you everyone for joining today's sessions. And I request all of our audience share our content as much as possible with your government, with your policymaker, corporation, and university. Thank you, our honorable speaker, for your continuous support to World Talent Economy Forum. Thank you. Bye-bye and take care.